A warm welcome again. A few housekeeping points. We will have presentations by the individual authors for their studies, and we will then take questions after each presentation from the room and online. If you have a request for an individual interview, please get in touch with Georgia from Page Medical afterwards. I'm Ulrich Baumann. I'm a pediatric hepatologist from Germany, and I have the privilege to be the current president of ESPGHAN, of the European Society for Pediatric Gastroenterology, Hepatology and Nutrition. We are proud to host this, as we feel, a very important meeting with over 4,000 delegates from around the world here in Vienna, and who will be with us and the city for the next coming days. A warm welcome again to all of you here and online. We hope you find the Congress stimulating. This session is being broadcast to media representatives online. It will be recorded and distributed accordingly afterwards. When you ask a question, please let us know which media outlet you are from and ask clear questions so we can maximize the use of this conference and you get most out of this session. Online delegates, you're also most welcome to ask questions using the question and answer box so we will see them. Please also state which media outlet you are from. Now over to my esteemed colleagues. First, I'm delighted to introduce Serena Coppola. Serena Coppola is a registered dietitian nutritionist, a PhD student of clinical and experimental medicine at the University of Naples, Federico II. Her research activity is based on the study of the pathophysiological basis of pediatric food-induced diseases, overweight, obesity, and metabolic syndrome, and on the identification of innovative dietetic preventive and therapeutic strategies for these conditions. She's presenting on Mediterranean diet in pregnancy and their implications in childhood, overweight, and obesity. Serena, we're looking forward to hearing from you.
Good afternoon to everyone. I would like to thank the organizer and the president for this huge opportunity to present in this press conference the results of the PREMEDI study, a randomized controlled study aimed at evaluating the effects of Mediterranean diet during pregnancy on the onset of overweight and obesity in the offspring. As all you know, pediatric obesity prevalence is growing at an alarming rate, affecting more than 1 million children worldwide. And this imposes the necessity of new effective preventive strategies. As all you know, the first 1,000 days of life from conception to 2 years of age are crucial to achieve long-term health outcomes and represent a strategic windows of opportunity to intervene under the prevention point of view. Different environmental factors are able to impact the obesity development through an epigenetic modulation of gene expression, and among them, maternal diet has a crucial role. Several retrospective observational studies have reported that Mediterranean diet during pregnancies, that is one of the healthiest dietary patterns, could be protective against the occurrence of pediatric obesity and overweight. But unfortunately, data are still lacking, and a randomized controlled trial aimed at evaluating the effects of a nutritional counseling promoting adherence to Mediterranean diet during pregnancies for the prevention of overweight and obesity are needed. For this reason, we have designed a 3-year randomized control study aimed at evaluating the effects of Mediterranean diet during pregnancy on the onset of overweight and obesity in the offspring. We have enrolled healthy women at their first trimester of pregnancy, and we subdivided these women in 2 groups. The first group received the standard obstetrical gynecological follow-up plus a nutritional counseling aimed at promoting adherence to Mediterranean diet. The second group received just the standard obstetrical gynecological follow-up by the gynecologist involved in the study. We, after the evaluation of eligibility and enrollment of women, we visit the women every trimester till the end of pregnancy. And we collected their clinical and anthropometric data. We assessed the adherence to Mediterranean diet through the MedDiet score questionnaire. And just in women of the first group, we performed a personalized nutritional counseling aimed at promoting adherence to Mediterranean diet. At the time of delivery, we collected 5 ml of cord blood, and we performed a complete physical examination of mother-child pair. Then we visited the offspring every 6 months till the 2nd years of age to evaluate the occurrence of pediatric obesity, overweight, assessing their anthropometric parameters. We show that at the baseline, the Mediterranean diet adherence was very poor. In women of both groups, the Mediterranean diet adherence assessed through the MedDiet score was very low in women of both groups, but this significantly improved just in women who received the personalized nutritional counseling since the 2nd trimester and until the end of the pregnancy. And we show that Mediterranean diet during pregnancy could be able to protect women with pre-pregnancy obesity from a weight gain out of the recommended range. Then, for the primary study outcome, we showed a 20% difference rate of overweight obesity occurrence at 2 years of age in the offspring. And then analyzing the epigenetic modulation of genes involved in the metabolic pathways of the offspring, we performed a cord blood DNA methylation analysis, and we show a significantly higher DNA methylation at the promoter region of the leptin gene in the offspring of women who received the personalized nutritional counseling to promote adherence to Mediterranean diet. This significantly higher DNA methylation in Mediterranean diet group characterized all the CPZ sites and indicates a reduced expression of the leptin gene, suggesting a potential action mechanism of Mediterranean diet in the protection of overweight and obesity in the offspring. Thank you very much.
Thank you, Serena. Very, very fascinating project and really important. So, questions? No, there are. So thank you very much, Serena. We move on to Dr. Marianne Samyn and hepatology. Dr. Samyn is a pediatric hepatology consultant at King's College Hospital in London. She's presenting on liver health care transition at the work completed by ERN Rare Liver and the Transition Working Group.
Very much. Like my colleague, I would like to thank ESPGHAN to kind of invite me to present to you today. And I think in particular to putting young people on the agenda, because I think they don't really get the attention they need. So I think the quote that we put in young people with liver disease deserve better. That will be kind of the topic of my talk. So I'm just presenting data on joint collaboration for ERN and ESPGHAN, where we did a survey on the availability and kind of the contents of liver transition services in Europe. Next slide, please. So I think overall liver diseases and particularly pediatric liver transplant outcomes have been excellent. And if you look at this is recent UK data, 68% have 30-year survival. But when you kind of next, please, when you look actually at different age groups, it's actually young people do less well. So you can see that the 9 to 17-year-olds, when they get transplanted, they actually do less well and actually more like the older age groups compared than the younger children. So what is this about? So young people are different. They make up nearly a quarter of the world population, and it's estimated about 10% of this group will have a chronic condition. Young people kind of include adolescents, 10 to 19, and then young adults, 15 to 24. Next slide. Now, why are we kind of 10 to 25? Why are we talking about that? Because what happens during this period is adolescent development. And we know that a lot of things are changing in young people's lives. And that's now been supported by a lot of research done, particularly on neuroimaging, and really suggests that there's lots of changes going on in the brain, which actually continue into the mid-20s. So kind of considering young people at the age of 18 being adults doesn't make any sense. And a lot of the traits we see in young people when we work with young people, like challenging behaviors, risk-taking behaviors, not taking medication, not attending appointments, are kind of, if you want, developmentally appropriate. Also, there is an increased prevalence of mental health problems in these young people, and they are often on kind of under or not diagnosed. Next, please. And there's no doubt that you, on top of being an adolescent, have to move on from paediatric to adult services. That's a huge change, because on this slide, you just see some characteristics of the teams that are set up in a very different way, where there is more multidisciplinary support, guidance from the parents. That kind of changes to the focus on the individual, relying on autonomous skills for personal care. Next slide. So these are the results of the survey. So we distributed using the ERN platform, also some national kind of organizations via ESPGHAN, and just actually came up with 86 responses from 27 countries, including 66 centers. And you can see that 14 of those were actually joined pediatric and adult centers. Now, in 16 countries or 37 centers, there is healthcare transition available. And you can see half of them is jointly organized by pediatric and adults. In the minority, it's kind of only organized by adults or pediatrics. But if we look at the centers individually, there is about nearly half of the centers who actually look after more than 100 patients a year, so quite high patient load, but you've actually got 20% of centers that look after less than 10 patients. So kind of a really variety of setup and kind of numbers of patients we are looking after. So this means that there is no healthcare transition in 29 centers. And when we asked what the reason for that was, is that the majority of kind of 56% of the centers actually quoted that lack of resources was the main reason for not having healthcare provision for young people. But what I think is even also worrying is that the second reason was actually lack of interest, both from either pediatric or adult teams to kind of have this dedicated service. And in general, when we ask everybody whether their health authorities in the different countries saw this young people or transition care as a priority, there was only 14% that said that was the case. So really disappointing. And interestingly, that was definitely higher in the centers who had healthcare transition compared to the ones that didn't. So what did we look at? One of the things that always comes up is the age at transition, and we can say that 70% of the young people are transitioned to adult services, kind of 18 plus 19, kind of up until the 19th birthday. So the majority will be transitioned then. But we also asked whether there was some kind of flexibility or whether some centers considered when patients were ready before transitioning them. And that was the case in about 20%, which I think is interesting because those centers definitely keep in mind that the development is different. We also asked whether there were exceptions. And again, that was kind of in half of the centers or the respondents mentioned that they did make some exceptions. And I think that's really relevant because we have now more data coming out, and we're presenting some of that in the conference as well, of increasing kind of problems with school development, school results, but also neurodevelopmental difficulties like ADHD and ASD are more common. We have quite a lot of patients with learning difficulties.
Sorry. Next one. So who is looking after these patients? I think interestingly, when we did the survey, in the majority of cases, it was kind of doctors and nurses, and actually other allied health professionals like psychologists, social workers, and transition coordinators were kind of there. Less than 20% of the centers reported having that support. So again, if you think about multidisciplinary support for these young people, that doesn't seem to be available in the majority of the centers. And only 16% mentioned that they had a dedicated transition coordinator. So definitely a minority. And also even the centers who had healthcare prevention for young people, there's only 20% that uses multidisciplinary team working or team meetings to discuss the patients. Then asking what the barriers were for kind of successful transition from pediatric to adults, you can see on this slide, and the two themes that came up as kind of the most common concerns is the patient or the family dependence on the pediatric provider, and the inadequate communication from the pediatric and the adult centers. So this was kind of results from the survey. What have we done next? We organized an ERN transition workshop, and this was really good. And I think what's been really enlightening is that we have been able to organize this with input from a group of young people that you can see on the picture, but also pediatric and adult professionals. And that's quite unique because lots of the things that get organized are either adults or either pediatrics. So in this forum, we actually had more adult representatives than pediatrics. And what we did, and what you can see on the right top side, is we kind of put together a group of young people with kind of had experience, and they will form a youth panel. And I think that is crucial because what we see in the survey is what we as professionals represent, but we really need to hear the voice from the young people. And so we've been working on 3 themes, which we kind of will develop some minimal standards for that. And that's kind of with regards to organization, communication, and education. So a lot more work to do, but I think this is a start of a really exciting program. But I think we really need health organizations, but also kind of all medical physicians, allied health professionals to really take an interest in young people, because we're actually striving towards not for them to only survive, but actually to survive, have a meaningful survival, which means that they can go on to do their jobs, study, and do whatever they want to do despite having a chronic condition.
Thank you, Marianne. Very important topic and very nicely summarized. So we move on to our next speaker. Hannah Juncker is a doctor of medicine at Amsterdam University Medical Center, Emma Children's Hospital, belonging to the Amsterdam Reproduction and Development Research Institute in the Department of Pediatrics in the Netherlands. The group is also associated with the Swammerdam Institute for Life Sciences Center for Neuroscience at the University of Amsterdam in the Netherlands. Hannah Juncker is presenting their study on vegan mothers' breast milk. Hannah.
Thank you very much for the introduction. And as my colleague said before me, thank you for the opportunity to present our results here. Well, we know that the maternal diet may affect the nutrient composition of human milk, which in turn might affect the breastfed infant and its development. And with the rise of vegan diets worldwide, mostly amongst young people and also amongst lactating women, concerns have been raised about the nutritional adequacy of their milk, especially since lactating women have higher nutritional requirements due to their milk production. We know that in a vegan diet, all animal products are excluded from consumption, and this may result in an inadequate intake of certain nutrients that are mostly animal product derived, and this may in turn result in low blood concentrations. And therefore, it is very important to know whether vegan women consuming a vegan diet, lactating women consuming a vegan diet also may have lower milk concentrations of these nutrients. 2 of these nutrients that are mostly animal product derived and that are very important for child development are carnitine and vitamin B2. Carnitine is a semi-vitamin, which is mostly important for energy metabolism. And it has been described previously that infants with a deficient intake of carnitine can have low blood sugar, and in very serious conditions, they can even have problems with their heart or with their brains. We know that vitamin B2 is an essential vitamin, which means that the body cannot synthesize this vitamin itself, and it needs to be consumed via the diet. And infants or newborns with low vitamin B intake may have anemia, and in serious cases, even neurological problems. It should be noted that in the context of a vegan diet, also vitamin B12 is a very important vitamin to mention, as it is also mainly present in animal products. But most lactating women, and also all the lactating women in our study population, took supplements of vitamin B12. And therefore, the aim of our study was to investigate the influence of a maternal vegan diet during lactation on the concentrations of carnitine and vitamin B2 in human milk. And we investigated this by setting up a case control study where we selected 25 vegan women from an already existing larger cohort of almost 3,000 lactating women. And we matched those 25 women one-to-one to 25 women who eat everything, so with an omnivorous diet. And of all those women, we collected milk samples, we collected a blood sample, and a lot of additional information about their pregnancy, about the childbirth, living situation, supplement intake, and stuff like that. And in the milk and the blood samples that we took of those women, we measured carnitine concentrations and vitamin B2 concentrations, and we compared those concentrations between our two study groups. And what we found was that for carnitine, the maternal blood concentrations were lower in the vegan group compared to the group of women who eat everything. And those concentrations were even below the lowest threshold of carnitine in this age group. However, interestingly, when we look at human milk, carnitine concentrations in milk are the same in both study groups, so between the vegan women and the women who eat everything. When we look at vitamin B2, we see that this nutrient is even the same in serum and in human milk. So vegan women and the omnivorous women have the same concentrations of vitamin B2 in serum and in human milk. And it should be noted that almost half of the women in our study took vitamin B2 supplements. However, when we compared the women who took supplements with the women who did not take supplements, we did not see differences in the concentrations in human milk. So to conclude, despite lower serum concentrations of carnitine in women consuming a vegan diet, these women a vegan diet did not influence the carnitine and vitamin B2 concentrations in human milk. And this might indicate that infants of breastfeeding mothers on a vegan diet may not be at risk for a deficiency of those two nutrients And we think that this information is not only important for lactating mothers themselves, but also for healthcare professionals and, for example, also for donor human milk banks, which collects human milk for the provision to preterm infants who do not have sufficient mother's own milk. And I think that's it. Thank you very much.
Thank you, Anna. Thank you for this stimulating talk. There's so much discussion about vegan diets. It is helpful to have your contribution. So we now have Gili Focht, Head of Research Unit in the Pediatric Department at the Shah Siddiq Medical Center, Israel, who's presenting on the early initiation of biologics in inflammatory bowel disease.
Thank you for inviting us to present our paper here at ESPGHAN. We're very excited. My name is Gili, and I'm presenting on behalf of the EPIRN group. And our question was, does early initiation of biologic change the natural history of IBD in pediatrics? So IBD, inflammatory bowel diseases, are chronic diseases of the bowel, digestive tract. And we've been using biologics to treat IBD in the past 20 years, and this has changed the way we treat IBD. And we've recently showed that despite the sharp increase of utilization of biologics in Israel, we can only see a modest improvement in outcomes of Crohn's disease and stable colectomy rates in UC. It's argued that this might be possible due to the late introduction of biologics within the disease course. So we wanted to explore whether early initiation of biologics is associated with improved outcomes in the pediatric Crohn's disease and ulcerative colitis population in Israel, comparing to the adult population. So what we do, we use the EPIRN cohort. This is a national cohort focusing on the IBD population. We use data received from the 4 Israeli HMOs covering 98% of the Israeli population. We identify the patients within the HMOs, the IBD patients, using IBD ICD-9 related codes and the use of IBD medication. The data is de-identified and sent to a central server. We also receive data from the Ministry of Health registries, also de-identified data. This is all aggregated and processed and summarized in a central server, which is then exported to an external server for analysis. And the algorithm enjoys an ascertainment of over 90%. We're now focusing on the pediatric population and those that basically initiated biologics within their first 3 years of the disease course. So we're looking at the patients that were diagnosed from 2005 onwards, and looking at the 4 groups here, starting from those that initiated within the 3 months of their disease course and up to 3 years. So we have 4 groups in total that we're looking at. Now, the ideal setting for such a trial would be a randomized controlled trial, where each patient at diagnosis would be randomized to the time when they initiate their biologic. And obviously, this is not ethical and not possible to perform in our settings. So what we do is we try and use real-world data and administrative data to try and deal with these questions and to emulate such a trial. But once we're using other data to try and emulate such a situation, we have to correct for different biases. And the more traditional ways are using propensity score, but these do not correct for all biases. That is why we use the target trial framework. So if you can imagine you're a pediatric IBD patient that was diagnosed, we do not know at this time point when this child will initiate biologics. So in theory, this child could belong to either one of these 4 groups. What we do is we clone our patient and we add our patient into each one of these groups in the treatment, timing treatment groups. Once our patient starts biologics, he's basically been randomized into their timing treatment group. And then what we do is we censor the clones from the other 3 groups. Once we censor these clones, we distribute the weight of the censored clone to the other remaining members of that group. And by that, we correct for immortal time bias, lead time bias, and confounding by indication. So when we're looking at our population, we have a population of around 5,200 pediatric IBD patients diagnosed from 2005 onwards in Israel. Of these, we have around 3,500 Crohn's patients and around 1,750 UC patients. We can see that among the CD, the Crohn's pediatric population, 62% initiated biologics within the first 3 years of the disease, with a lower percentage of 32% among the UC pediatric population. When we're looking at the median time to biologics from 2005 onwards, we can see that both in the adult and the pediatric population, there's a constant decrease in the timing, reaching a very low median towards the end. Now, when we're looking at our outcomes, so first, let's focus on the surgery among the Crohn's population. Now, let's look at the pediatric versus the adult population. We can see that in the pediatric population, there was a decrease between the ones that initiated early on within their 3 months of the disease compared to those initiated between the second and third year of the disease of 8%. This was not statistically significant in compared to the adult population, where we see a change of 6% between the two extreme groups, with a number needed to treat of 17, but for this analysis, we did find a significant, statistically significant decrease. This might be in light of the fact that we have a relatively lower number of surgeries within the pediatric population, but we can see a trend here. If we're looking at the steroid dependency, so here we can see that actually among the adult population, we see a decrease of 10% between the two extreme groups, with a number needed to treat of 10. Obviously, this was statistically significant. In the pediatric population, we do not see this decrease. And the reason for that is probably in light of the fact that the current guidelines call for treatment of EN in pediatric Crohn's disease and not steroids. The recommendation is using EN. So this is probably what we can see here. Looking at the outcomes of the ulcerative colitis population, focusing on colectomy, we can see here, similar to the adult and the pediatric population, we do not see a significant change between the groups, and this remained similar between these groups that did not reach statistical significance. Looking at the steroid dependency, we can see that both groups, both the pediatric and the adult population, reached statistically significant decrease between the two extreme groups of the 0 to 3 months of their disease course and the second to third year of the disease course, with a change of over 20% for each one of these groups, and a number needed to treat of around 3.5. So let's conclude what we can see here. So for Crohn's, there was a numerical and small trend of lower surgery rates in the early initiators of biologics in children versus the later initiators, 8% in the pediatric versus 6% in the adult. It did not reach statistical significance in the pediatric population, and it did in the adult. This probably is in light of the sample size that was too small. As far as steroid dependency, so unlike the adults, where we can see that the early initiation of biologics did reduce the steroid dependency, in children we did not see that, and it's probably in light of the high use of EN in the pediatric population. These data support introducing biologics early only in high-risk patients, and we would like to emphasize that the expectation from this strategy should be realistic. For UC, we can see that early introduction of biologics decreases steroid dependency use both in adults and in the pediatric population, but there was no difference in the colectomy rates. And these data support the step-up treatment approach of starting with 5-ASA, then thiopurines, and then biologics, unless the patients have require repeated steroid courses. I'd like to emphasize this is administrative database. It's not a randomized controlled trial. And this should be taken into account with the limitations. Thank you for your time.
So we now have 15 minutes for questions and answers. I see so far there are two anonymous questions. It would be good if you could, if you gave your journal or your media outlet for us to know this as well. So I'm starting with the first question. And the first question, to my understanding, goes to Dr. Samyn. How do healthcare systems need to change to support young people better?
Thank you for that question. I think they first of all need to acknowledge that young people are different. They need to acknowledge that young people also include young adults who are seen by adult services. So they really need to acknowledge what the traits and the challenges are for this population so that they can actually address their needs. There definitely needs to be more multidisciplinary support for these young people, and including allied health professionals, psychologists, dietitians, social workers, pharmacists. They really need to kind of be part of the team. And the other thing which is really important is that they make resources available so that this can put in place. I'm afraid that the current healthcare system is very much set up of being reactive, and I think that's even more relevant in adults than in pediatrics. So when there is a problem, you kind of you try to solve it. But we know with young people, if you try and address their issues they have or the challenges they have with regards to, for example, paying for medication or accessing healthcare, then you will actually work proactively and prevention. But that's kind of a lot of the healthcare setting, but a lot of could be very cost saving if that would be addressed more. And I think that's probably counting for other services as well. So we just need to change the way we look at healthcare provision.
Thank you, Marianne. I would say the next question also goes to you. Perhaps in the interest of time, we can try to respond in a brief way. The question reads, what can the public do to get better transition services?
Yes,
I think an important question.
Yeah, and I think that's where the youth panel comes in, because I think we need to hear from young people. They need to demand that they have better care. I think that those voices are much louder than any of the things that we put in place. Patient support organizations are also very heavily involved. And again, most of these are either pediatric or adults, and often young people don't really find themselves. So kind of thinking about peer mentoring, peer support will be really helpful. But I think people need to ask for better care.
Clear statement. Thank you very much, Dr. Samyn. The next question again doesn't say specifically, but I presume goes to Dr. Juncker. Do you think a sample size of 25 is sufficient? And are you going to follow up on to see if these results are maintained?
Thank you very much for this question. I think it's also a very important question to ask. Although our study was, of course, set up in an adequate way, we acknowledge that a sample size of only 50 women is still a relatively small sample size. We think it's a good start, but of course, results need to be interpreted with caution. And of course, we hope the results can be replicated in a larger study population. And as to the second point of the question, if we are going to follow these women up to see if the results are maintained. At this moment, we are not planning to follow these women up.
Thank you. Thank you, Dr. Juncker. And there is another question. A question to Dr. Coppola. And the question says, what is next for your research?
Thank you very much for this question. My next step of this clinical research are to investigate the effects of this cost-saving strategy for the evaluation of the occurrence of other non-communicable diseases such as allergy and infection, for example. And our objective will be to enroll more women because in this pilot phase of this study we enrolled 50 women per group, so a total of 100 women completed the study. So the results that I've showed in this presentation are related to 100 offspring. So enrolling more women, for example, in a multi-center study could be useful to evaluate if these results could be reproducible in other centers. So that's all. Thanks.
Thank you. Any more questions? If there are no further questions, thank you, Dr. Coppola. Thank you, Dr. Samyn, and thank you, Dr. Juncker. It has been really enriching to hear your presentations and to have the opportunity to share this novel research with you. Thank you for your interest in our work. I hope you will have an opportunity to follow on with ESPGHAN, and we see us in the future. If there are any remaining questions, please go to espghan.org. Thank you very much.